Alright, we're going to go ahead and get ready for rapid sequence intubation. I'm going to go ahead and make sure I have my standard precautions on, got my gloves here. First thing we're going to do is look externally to see if we have any masses, if the patient's obese, anything like that, anything that would predict a difficult airway. Next thing we're going to do is evaluate 332, and that is if we can open the patient's mouth 3 fingers widths, going from the chin down to the hyoid bone 3 fingers width, and then from the hyoid bone to the thyroid cartilage there would be 2 finger widths, and that is also a predictor of how difficult your airway will be. The third thing we're going to do is the Mallampati, and we're going to have the patient stick their tongue out best they can, and then see how much of the posterior oropharynx we can actually visualize, and then give it a grade between 1 and 4, 4 being difficult and 1 being a very easy airway. The fourth thing we're going to do is look at O, which is obstruction, see if there's any abscesses, soft tissue swelling, anything in the mouth that will predict a difficult airway. And then we'll look at neck mobility. Is the patient secured to a long spine board or anything like that? And that'll be our lemon that we're looking at first. The next thing we're going to do is inquire about any allergies the patient may have and talk to them about any previous reactions they might have had. We're going to explain to the patient the medications that we're going to give them and what the reasoning is behind giving these medications. Then we're going to look at having our partner, making sure we have clear roles defined, giving the partner, one of them is going to be doing just med administration, one of them is going to be doing ventilations, and make sure they are clearly assigned to those things. We're going to go ahead and have our partner start pre-oxygenating the patient using a BVM, high flow O2, and rate of 10 to 12 breaths per minute, and just kind of working with the patient at their regular rate and assuring adequate ventilation there. Next thing we're going to do is take our SpO2 and make sure we're monitoring that. If we can get CO2 readings and ECG readings, we'll monitor those as well. And then we'll go ahead and prepare our equipment and go ahead and make sure one of our partners is getting a patent IV established for us. So we're going to check our equipment here. Our laryngoscope blade is white, bright, and tight. And our ET cuff here is holding air. There's no leaks. It's properly sized, everything like that. And then we do have all of our extra CO2 devices. We have a backup airway if necessary. We've got securing devices, everything like that. Then we're going to look at our medications. And we're going to be giving etomidate here for a sedative. And we're going to check the 5 rights, make sure it's the right patient, the right route, which we're going to give IV, right medication, which is etomidate, right dose, and that'll be protocol specific. And then also we need to be checking our expiration date and clarity for that. Our paralytic is going to be succinylcholine, and again we're going to check the 5 rights on that and getting those prepared and drawn up. Dosage specific on your local protocol there for those dosages. We're going to consider atropine for anybody that's pediatric, and then also any adults that are having some bradycardia. We want to consider atropine just in case they do vagal down some. Any head injury patients will consider lidocaine in case that is necessary. All right, first thing we're going to do is once we've drawn up our medications, we're going to go give our sedative first, our etomidate, and give that IV, and then after that we're going to go ahead and give it about 30 to 60 seconds and then give our paralytic, which would be our succinylcholine. Then once those have taken effect, our patient will become easier to bag, and then we're going to make sure we have the appropriately sized airway here and go ahead and insert the airway and get that bag out of the way. Make sure there's no gag reflex there, and then we'll have our partner go ahead and continue pre-oxygenating the patient and preparing for everything. Once he's pre-oxygenated, we're going to go ahead and have him remove that, and we're going to have him remove the OPA. Go ahead and use our laryngoscope here and perform oral tracheal intubation, inserting into the vallecula, taking our ET tube there and visualizing it passing through the glottic opening in the vocal cords. Go ahead and remove our stylet. Go ahead and inflate our cuff. Make sure our cuff is nice and tight there. And and then we're going to place a end-tidal CO2 on the patient, and then continue bagging the patient with high flow O2. We're going to note chest rise and fall, and then we're going to auscultate breath sounds and make sure we do have absent epigastric sounds. Alright, we're all good there. We're going to make sure our ETCO2 is all good and that we are getting a positive waveform there. And then we'll go ahead and secure our ET2 while our partner continues to oxygenate the patient. Nothing has shifted after we've done that. Alright, then we'll consider the need for a cervical collar, just kind of help keep everything in place. Since the patient is paralyzed, they won't be able to hold their neck very well. So we'll consider the need for that. And then we'll continue to monitor our CO2, SpO2, ECG readings, and assessing the patient's vitals every 5 minutes. If we need to give additional sedative doses, we can consider that per your local protocol.